Hello, and welcome to the In-Network podcast feature, Designing for Health. I'm Nordic's Chief Medical Officer, Dr. Craig Joseph. In this episode, I talk with Dr. Bonnie Hartstein Shweiki, an emergency physician and former military leader whose career was shaped not by following her passion, but by following her frustration. We explore how that mindset led her to drive large-scale improvements in access, patient flow, and safety across the military health system. We dig into practical strategies for building high-reliability organizations, from daily safety huddles to empowering the most junior team member to speak first, and why most healthcare systems still struggle with psychological safety and non-punitive improvement. We also get into what she's seeing now on the front lines, poorly designed workflows, EHR risks hiding in plain sight, and where AI might actually help if we don't repeat past mistakes. If you're responsible for clinical quality, operations, or culture, this one hits close to home, for better or for worse. Let's plug in. Dr. Bonnie Hartstein Shweiki, welcome to the podcast. How are you today?
I am great. Great to be here.
I'm excited about this. You and I met at a conference, and I heard a little bit about your background, and I thought this is the time and this is the podcast for you to be on. So, well, let's start at the beginning. I'd like to kind of learn a little bit about the folks that we're talking to. You have a genuinely unusual background. You started, I think, in college and undergrad at the University of Michigan in ROTC. And then went to Korea, not as a physician, but as an ambulance platoon leader, ultimately. Then you went to medical school and decided you wanted to be a pediatrician, which, of course, we all agree is the highest of all specialties and callings. But then you ended up doing mostly emergency medicine. So, tell us how that happened. How is that a thing?
Yes, thank you. Thanks, and great to be here. Well, I started in in pediatrics. I have a strong interest in health policy. I'm originally from the DC area, so I think I was kind of naturally drawn to the advocacy and support that pediatricians provide just, to patients one-on-one and then overall. And then as it were, 9/11 happened, the real 9/11. And I was actually the attending on on the pediatrics ward at the time, walking the halls, checking on kids as we watched the day unfold on the TV screen. It looked like a Bruce Willis movie at the time. It was really jarring. And I had spent 3 years on active duty as a medical service corps officer. As you mentioned, I served in Korea, and then I had gotten into hospital administration jobs at Walter Reed in Washington, D.C. And just the events of the day and the moment in time, I felt very drawn to sort of a more operational focus. Although now, few decades later, pediatricians have served valiantly overseas in many roles in conflict. So, but at the time, it was really, we were so used to peace, we really didn't know what was going on. And I had always loved emergency medicine, so I had the opportunity to do another residency. The Army's good that way; they give you a lot of different options for your job, as we'll probably go through as you go through the rest of my career, which is eclectic, but that's kind of the life of being a military physician, is you get to try a lot of different things. So I went and did another residency, and that's kind of the short answer there as to how I wound up in emergency medicine.
I did not realize that you did a complete residency. How was that kind of going back? It's very rare for physicians, at least the ones I talk to, who have completed a residency or fellowship and then I'm going to go do that again.
Right. Well, the short answer is, I could have, most people in that position as pediatricians would do a PEM fellowship, but the military at the time wasn't supporting that. So even though, at the time, now they have drop downs where you're force function into when you fill out applications for things. But at the time it was a paper application. I wrote in pediatric emergency medicine, and they called me. They said, you can't just make things up, So that was the only option.
Okay, that's that is one of the benefits of paper, is you can make stuff up. But now there's these things called forcing functions, and it's a drop-down list, and you better choose something from that drop-down list. I get that. All right. Well, when we were preparing for this conversation, you had mentioned your personal mantra rules that you live by. One is, follow your anger. And you had told me that following your anger can explain some of your career. So, tell me more about that. Most people would tell college graduates to follow, their passion, but you followed your anger. I like it. I think I've probably done it, but I'm not sure I understand it.
Yeah, well, thanks. The truth is, the emergency medicine we've kind of come to now. I'm emergency medicine physician. I deployed 2 times as an ED doc, and as I was in the clinical setting, though, I think after you follow your passions and you seek out the training that you're drawn to most, you start living the life of whatever it is you're doing, and then naturally there are things that bother you with whether it's administrative or systems, etc. And I was naturally drawn to leadership positions, and I became involved in a Lean Six Sigma project within the emergency department to streamline our patient flow and to reduce wait times and left without being seen. And that got me in front of our general officer who was running the facility at the time, who asked me, you seem to have a grasp of this and, be maybe geared towards other jobs. Would you be interested in running primary care? And so while I was a pediatrician, at the time I wasn't a family practitioner and I wasn't really that excited about going back towards a outpatient setting. But what I did know was that I was pretty annoyed that so many patients were winding up in the emergency department with non-urgent conditions. So because I was frustrated with a system that wasn't providing enough access to primary care, I agreed and put my name in the hat and was ultimately chosen to run the outpatient services, Brooke Army Medical Center, which at the time was and still is quite large, 8 different clinics, optometry clinics, uh, readiness clinic for soldiers, et cetera, in addition to a bunch of different family practice. So then I became trying to streamline work there. There was problems with getting our patients into the system because of the phone system, which was centralized and very wasn't working in a way that was agile enough for us. And I found that the place they were running the phone system was in the sort of nascent early years of cooperative work within the Department of Defense, which became eventually the Defense Health Agency. But the Army and Air Force, big presence in San Antonio, was trying to kind of joined together, managed by this office run by someone. One of the executives in that office was the chief of clinical operations, a physician, and that person oversaw the phone service. So I said, I want that job. So my frustration with the phone service led me to this position within, overseeing really the integration of care in the system. And then, one thing again followed another, and I wound up going to Baylor, getting an MBA through the Army Baylor program, exceptionally great executive program. And I then decided to take on quality and safety in the military. One of the things that always bothered me was how slow it took to get your credentials and privileges established at a new facility. So I sort of took that on as a pet project and helped streamline credentialing and privileging. So my idea of follow your anger is when you find something that really bothers you that doesn't work, maybe that's an indication that you have the passion to fix that. So it's anger and passion kind of together, but anger and passion are probably flip sides of the same coin, I think, is we might agree. So there you have. That's a long answer to a short
No,
question.
it makes complete sense. And I think I think a lot of us, myself included, if we look back on our careers wherever we are, oftentimes you're right. It's the things that annoy us, and why can't this be better? And I have ideas to make it better. And then when you find someone like that general is like, hey, if you think it could be better, go fix it. Maybe just to get you out of his hair or her hair. But in fact, you're like, okay, I will. So that's a great story. And I think that's a good, you should start thinking about how you're going to make that into a graduation speech and go on the college or med school graduation circuit. I would sign up for that. I would not go do another residency
I think I'm done with that. No.
Get another degree just to do that, but I might listen to it. Well, one of the things that you had mentioned that you were, involved with and proud of was this this top six initiative. Tell us, like, what is that? What are we talking about? What are the six things? And was this part of your brilliant plan to get irritated by things and then to go and fix them, or is this different?
Well, it's nested. I mentioned credentialing and privileging for a period of time. I was the director of the Army Medical Department Quality and Safety Center, and that was one of the elements in the portfolio was credentialing and privileging. But we managed much more than that. We really oversaw the accreditation for the military, the Joint Commission, all the Army hospitals. We did all the risk management, medical malpractice, infection prevention, etc. So all of this was under the portfolio. May have wound up there in part because of my interest in improving things and realization in Army Baylor that we really didn't have a champion in quality and safety in Army medicine
Mm,
at the time. But at the time, really, the entire military system was beginning a transformation and a journey towards improvement and transparency and accountability to itself, really. And there was an effort underway to increase measurement and to you know measure quality and measure safety. So the top six was sort of along the journey. I'll try to frame it kind of quickly. So we started measuring, and we started also deploying what we called a reset team, which was a group of disinterest. Well, start over. So we realized that we were measuring. So we started to measure sentinel events, as you call them, events that should never happen. So the quality and safety space, we're looking at wrong site surgeries, medication errors, etc. And when you have a sentinel event in your Joint Commission accredited hospital, which 80% of the US hospitals are, you need to do what they call a root cause analysis, an RCA. So, we're serving 4 million of 9.6 million patients, worldwide facilities, and we endeavored to figure out what was the reason why we were having, we weren't having a lot, but they were happening. And so we deployed this reset team to help the local facility do their root cause analysis, because when you do something infrequently, it's difficult to go through the process and to dedicate the staff. So we
sure.
had a dedicated group of experts. And when we look back at the problems or the reasons why we were having these events, it kind of boiled down to a few recurring themes: um, communication, lack of empowerment of junior people to speak up, and systems that weren't necessarily being followed. It wasn't that we didn't have processes and procedures in place, we just weren't doing them. So we were also convening national or international training events where we were taking hospital commanders and kind of training them in all of our safety standards. And they were happening biannual, these training exercises. So one exercise was about to happen, one of these big training platforms, and we were going to share all the reasons from the reset, and all our conglomeration of about a year and a half worth of data. And that training exercise got completely snowed out. So we wound up having to find a way to package all this information. It was a little bit before we used so many platforms where we're just dialing into things. And the senior commander at the time said, I want you to do this in terms of what we call an operations order. An operations order is when you say it's a way of military communication. You go and do this. So he said, I want you to package this all up and tell people what to do. We said, well, we don't really, have things to tell them to do. We were just going to share the information. He said, well, make it so that, no joke, people are going to do these things. So it caused us to go back. And a lot of these things we had already been doing or had come out over the years as we were maturing and becoming more aware of safety and quality. And so they're really industry standards, but we had to package them into this very succinct. And this general officer who's terrific and a mentor of mine and really very good at making things as simple as they can be, but not oversimplified. So out of that, we developed what we called the top six. And we deployed this across Army medicine. And they were 6 practices that modeled, yeah, high reliability organization practices and put them, operationalize them into action.
Okay. And so what were the six? I mean, first of all, I'm fascinated by kind of all of this all started because of a weather event, right?
I know, it's great. And when I tell the story, I have a picture of a grounded aircraft, which was when we were so excited about doing this and rolling and telling everyone our findings, and then we were just shut down.
Yeah. But at least you weren't shut down by, someone, or it was God really that shut you down. But
Exactly.
it turned out okay. It turned out okay. So like, what are some of those six practices, and how did you kind of get them spread throughout the, what would you say, it was Army and Air Force, or
Well,
all
it
of
was at the
military
time.
medicine?
Right at the time that it happened, we have, since the military health system has now joined all their hospitals together under the Defense Health Agency. But at the time, we were still operating as Army, Air Force, and Navy hospitals. And the Navy and Air Force were doing similar things. And eventually, when we all came together, this, at least, it's been rebranded a little bit from the top 6, but they're still, it's still in existence in the military health system. But we like to take credit for having developed it in Army medicine. So
Okay.
the top 6 practices were leader daily safety briefs, where the head of the hospital would every single day receive information. We called it a tiered huddle system. So there was also unit-based huddles. So every day, every unit within the hospital would meet and discuss as a part of their meeting, any daily safety event that had happened in the last 24 hours that needed to reach leadership. So that was number 3, was the unit-based huddles, and it would go to 1, the leader daily safety brief, which we called number 1 because of the importance of leaders taking responsibility for overseeing the cultural of safety and psychological safety in their organization. So a tiered huddle on the ward or in the clinic, the team meets, discusses patients of the day, and specifically calls out any safety issues that are happening in the last 24 hours, or of note on the ward. This then goes to the senior leaders that same day, and they are in, there has to be a dedicated communication between the unit and the head shed, and they discuss that at the leader daily safety brief at the higher unit level. I mean, at the leadership level. And then you also have senior leadership rounds, where the senior leaders of the facility were charged with, once a week, going through the hospital. I think it was actually in the beginning once a month, but then we increased the frequency, but to the places where care is delivered and interacting with the staff and asking about safety issues, or, with a specific idea in mind, going and interacting with the staff, as to be transparent and open for frontline communication. So that was happening kind of at the leadership level. Those were the first 3. Then we had 2 that we said were kind of happening with frontline staff. And that would bring us to number 4 of the top 6, which was using SBAR, or situation background assessment and recommendation, as a communication tool. So we wanted in staff, when they communicated with each other, to frame their patient handoffs and discussion. It wasn't the full patient handoff. That was kind of, we had to clarify, followed a different, more extensive communication. But just in terms of communicating important information, to use that, this is the situation, this is the background, this is my assessment, and this is my recommendation of what you should do, so that we could tighten communication between frontline staff, just in their daily communication.
Sure.
And then number 5 was instituting surgical brief and debrief before every operative procedure. And that was also very structured, with a specific format and a poster that was then populated and sent, printed and posted. Posters were sent around the world to all the different ORs within the military, within the Army. And then finally, the 100% use of the universal protocol, or final timeout, as we call it, before every operative or procedure. So, which was already a standard, but like I said, these were not necessarily all new. We've been using team steps for a long time, but this was like packaged and branded as the top.
Yeah. Well, I think a lot of them, some of them are tried and true, but, there's certainly something to be said of, well, we have in general, the timeout, but it slips through the cracks sometimes. And those are the things that you really need to quash, right? It needs to be a universal thing. One of the points that I found most interesting in looking at some of the things that you had kind of worked on was the um, getting to the point of saying like, well, who's going to talk first at some of these either debriefs or safety timeouts? And I think at some point you had said, well, the person who is the most junior gets to talk before the most important person in the OR, which is often the attending physician. Can you tell us a little bit more about that, and why do you think that was important?
Yeah, that was really an important part. And I'm looking at our copy of our brief and debrief checklist. And the debrief specifically, the what could have gone, what went right, what went wrong, anything we could have improved in that procedure. It specifically says to start with the technician. And that was driven by our findings in the RCAs, where we saw that sometimes it was the technician that the scrub tech or that was counting the sponges and thought there was maybe a miscount, but was shunned aside by a higher level team member who said, oh, you just must have gotten it wrong. So we wanted to give the person who, this kind of is part of the high reliability organization deference to expertise concept, where you want the expert in their area to have the freedom to be the expert and talk about it. We thought if the most junior person or the more junior people on the team weren't given that opportunity first, and a more senior or more, maybe the surgeon said everything went swimmingly and it was terrific, they wouldn't feel empowered to say anything. Well, from what my viewpoint, I thought that we didn't have enough blood and we had to run down and get it. Would have been good to know this at the beginning. So that type of thing was why we flipped the debrief to let the more junior folks speak first.
Yeah, it's these little things in design, right? When you were designing that program that can really make the difference. Because after the attending speaks, who's going to contradict him or her, right? Like
Right.
that most most junior folks, whether in the military or not, are not going to say, well, I thought this was bad from the very beginning. They might say that if they're the first to speak, though. And so I think when I heard you talk about that, I thought that was pretty brilliant. One of the other things that we discussed about root cause analysis was kind of doing it in a non-punitive way. And oftentimes that doesn't happen, right? Like something went wrong. That clearly means that someone made a mistake. We should find that person and punish them, right? How do you, how, I guess sometimes that's correct, but oftentimes it's the system, right, that caused the problem. It's not a person that works in the system. So how did you have success in trying to make sure that this was, not putative? We're not looking for someone to blame. We're looking to make the system safer for all of us.
Well, by design, our organization had two arms that were supposed to be really separate. One was the root cause analysis, which was really looking for system problems. And there was a risk management element, which looked for any type of, it was really more under the legal umbrella of looking at events to see whether there was a standard of care met within the delivery of care space. But this group that was going to look for the root cause was really focused only on the process and the procedures and how the events unfolded. So that was the lens through which this team looked. And no people were harmed in in the exercising of that event, of that root cause analysis group. And we had a physician, a nurse, a human factors engineer, and some administrative support. And we went through a very prescribed root cause analysis framework to do it. So I think the most important thing towards in getting towards a safer environment is that concept of psychological safety and
Uh,
the use of just culture. I mean, it's my own personal opinion that the reason why the healthcare industry hasn't achieved the same safety record as the airline industry, and it's discussed a lot, is that we are always afraid of legal ramifications from events. And so we don't share information. And we live in a much more punitive environment. So we can't learn from each other and kind of operationalize these regular either near misses or errors because everyone's hiding. So
Mm,
this enabled us to look at the system and and kind of not punish people in that space.
yeah, it's that is a lot of work to actually make that happen. And to your point, other industries have figured it out. Of course, they're different than healthcare, but this is doable. And kind of getting that information out there and resetting the culture of a large healthcare system or a small rural hospital equally difficult. So hats off to you for moving the at least the army in the right direction. Um, I wanted to pick up on another point that you had talked about, one of the top six initiative. You had mentioned, I don't think you used the word forcing, but I'll use the word forcing senior leaders to actually walk around to where care was provided. And you said that you started off as pretty much once a month that had to happen, but then obviously something positive was coming from it because you changed that to every week. So what were people seeing when they were actually forced to go and see where patients were cared for? Why was that a win?
And, I think being able to just interact with, we weren't, and in fact, when we measured this, we did measure frequency, and we measured returning to the location where the problem was and providing feedback. So
Mm,
we didn't actually measure what people were saying. We were measuring that people engaged and that they provided feedback, because data shows that if you go and you ask the question, hey, what's wrong, and you don't go back with feedback or fix it, you can reduce engagement and increase, dissatisfaction among staff. So one of the areas we did collect data in terms of what was wrong was there was a program within the ORs that enabled us to categorize issues during the surgical debrief. So it was capturing what was potentially delaying surgeries. OR efficiency is a big deal. So that was actually an automated. So we were able to look a little bit more at granularly what was causing some delays in that space. And that was also very informative and important data related to some sterilization delays or room turnover, etc.
okay. All right. Love it. I did not realize that part of the magic was going back. I thought it was mostly, hey, you actually have to look people in the eyes, and it's one thing to get a report about delays, but it's another thing to talk to patients and service members who are on the receiving end of those delays, but that they went back and said, hey, we fixed this, or this is not fixable, but there are other things that we can do to mitigate it. I'm kind of shocked that they did that. How was that? Just did that just like organically occur, or were there parts of the program where, yeah, if you went to this clinic this week, next week you were supposed to go back with answers?
No, we built that in, and we had partnered with the Institute for Healthcare Improvement, Boston, and done a lot of work with them. And that was one of the things they drove home a lot in their teaching was, yes, leadership walkarounds are important, but if you're going to do them, and you must commit to engaging with the people for follow up, or it really can diminish engagement. So we built that in as an important metric. And anyone who wants more information can read my New England Journal of Medicine Catalyst article on the top six that goes into this in detail and shows the data and and gets a lot more specific into how we did each step.
And we will have a link to that article in the show notes. So thank you for mentioning it. Well, let's catch up to where you are now. So you retired from the military, and then since you don't apparently understand what retirement means, you're now seeing you're pulling some regular shifts in the emergency department. What has anything changed, or is there do you notice a big difference between kind of practicing military medicine and out in the civilian world?
you know, Medicine is medicine, and so the delivery of care is, I think every hospital has its own quirks and differences. I mean, I do think it is interesting to, you say like care as perceived or work as perceived and work as actually delivered. In working in the safety and quality space for so long, and going into the emergency department, you see just how many opportunities there are for safety or quality issues. Just I can't work one shift without thinking like, why am I allowed to make this potential mistake? Or why did I almost chart on the wrong patient? Or, why did the system let me order a chest x-ray that wasn't stat, for goodness sake? I need that chest x-ray. Of course, I'm in the ED environment. There is no day on no shift, no minute of any shift ever that I don't need something stat. you know
Yep.
so how is the system so poorly designed in some ways? So I have a lot to say about the way that we support clinical work, at the deck plate, when you're actually delivering the care, and how much more could happen to provide safe care.
You're seeing it now. Now you can't unsee it, right? And I think that's you just gave a perfect example of an electronic health record that is not functioning or poorly configured, not functioning as well as it could, or definitely poorly configured. You're in an emergency department. Almost all of the orders that you're writing to be carried out in the emergency department need to be done as soon as possible, right? Stat. And how is it possible? Like you would expect that if it's even allowed, if it's even a consideration for you to order something like a chest x-ray for tomorrow, that you would have to jump through a bunch of hoops. Like, are you sure? Is that really what you mean? Like, why would you do this? Go talk to someone before you do this. Those kinds of things, which are capable. We're always, being involved in this work, there's always exceptions, right? I've
Sure.
joked I've joked that as a pediatrician, I need to be able to write an order to hold the baby outside the window. Have the mom hold the baby outside the window. Now, I can't imagine ever needing that order, but boy, oh boy, I bet you there is a time where some weird one-off, one in a gazillion kind of orders make sense. And, I think I should be allowed to, I need to be allowed to write that order, but it shouldn't be easy. And it should have multiple, like first the nurse is going to look at me like, are you sure? And then I would imagine some other levels of oversight would come into play. But yeah, so obviously we talked earlier about you getting angry when you see those kinds of things. And it sounds like you see them all the time now, although I suspect you're not the only physician at the emergency department who sees them, but probably one of the few physicians who understands from the quality and safety kind of viewpoint that it's a risk, even though you didn't fall for it, even though you caught yourself before you ordered that chest x-ray to be done in 2 days. It's an opportunity for a miss. It's a near miss. And those are just as scary. And they add to the stress level, right? From the clinicians who are trying to check themselves. And that's necessary for sure. But there are lots of things that we don't need, extra pressure, extra stress that we don't need added to our lives, that some of these systems, be they electronic health record or the way tubing goes together, that could be better. Are there other things that you're seeing kind of outside of the ED, but still in your work, that are bugging you because you want to fix them? Or is that when we next interview you in a few years, will you be fixing these problems? You can tell us the truth.
um, I'm sure there are other examples. I think I'm most interested in trying to. Yeah, I think that we as clinicians are just so used to, and nurses, we just take the system as it is, and we don't really, everyone's too busy to really think about the fact that the system it isn't really structured to support us in the best way it could. The electronic medical record is a list of patients, but they're arrayed in rooms around the ED that are then numbered. And imagine working with kids. You've got the 6-year-old in bed 7, the 7-year-old in bed 9, the 9-year-old in bed 14. It gets super confusing. And then you've got a list, and it's sorted in a way that is or isn't intuitive, easy to chart on the wrong patient if you're not careful.
Sure.
But we don't. But it's the fact that we don't, and that we don't make more errors, to me is astounding. I mean, I think one of the things I learned when we were doing the work at quality and safety was how poorly trained to work as a team member I was
Mm,
as a physician. You know, because we have these systems that create risk and set us up for failure, if you will, we have only each other to rely on. And so I now partner with my nurses, implicitly. Like I share with them my thought process. I tell them what I'm thinking and what I'm ordering. I ask for their input because they may have heard something that helps me with the diagnosis or have an opinion or frankly catch a wrong order if I tell them I'm going to order one thing and then I order something different. They may come back and say, "Did you mean to do this? You told me you were going to." So, I think right now we're kind of all watching our lanes all the time, making sure that I get calls from the pharmacist. Did you mean to order it at this level? It's a little bit over, it's a little bit under. One time I ordered a medication exactly as the system told me to, and then it was still wrong. So they called me. I said, I just ordered what it, defaulted to. Oh, but that's still wrong. So, my hope for the future and my prayer is that the AI wave we're about to encounter is able to intersect this space and be smart and prevent me from doing things that I shouldn't be doing or don't want to do. Get me out of my own head if I'm making a cognitive error. Question why I've ordered something of the wrong level, or charted up a physical exam for someone who isn't that age or who doesn't have that chief complaint.
right. Yeah, no, that makes sense. I just want for the record to point out that you mentioned AI before I mentioned AI. So, I'm concerned, as maybe you are as well, about how we implement AI. Right? Like, I don't think anyone's looking for technology robot overlord to be second guessing everything that we do. However, I think that like you just said, hey, tell me if I'm making a judgment error or trying to get, tell me I need to get out of my own thinking here, out of the way, because this seems to be a major problem. This direction that I'm going in seems to be a major problem. We all want that. Like we all want someone looking over and saying, it's not a really big deal if you're giving amoxicillin instead of a cephalosporin for an ear infection because it's going to get better with either of those, or it might be a virus anyway. So it just doesn't matter. That's a minor thing. But to your point, hey, am I missing a big part of the differential because I'm thinking one way because I've seen a lot of patients with that problem and I'm ignoring that the other way. Certainly we all want that AI expert but to be watching, but it has to be implemented in such a way, unlike clinical decision support was initially implemented in the EHR, which is often telling you to do something that you were just about to do. There's nothing more infuriating than that. So I hope we don't repeat the errors of our ways when we're implementing AI. Have you any thoughts about that, or why don't you just tell us about the AI startup that you're working with? I just made that up. I'm assuming that you're working.
I was like, am I?
I don't.
That
You
would be
must
great.
be. I believe it's a law now. I think every physician has to be working with an
Working
AI
with an AI
startup. Isn't
startup.
that not true?
Oh my gosh. You know, my hope is that at least clinicians are involved in the development of AI in the clinical space, as opposed to the EHR that was pretty much developed by non-clinicians and kind of thrust upon clinicians, and that's why I believe it's so counterintuitive. If we are able to ask these very difficult questions in the space, I don't know that I have all the answers. I know now my chat GPT is starting to know me better, and that's probably scary, but thinks I'm very smart and has asked excellent, well framed questions.
Oh, that's
I
funny. It
don't know
says the
if
same thing to me.
yeah.
Wow.
But no, I do think that um, that bringing together collective minds in this space is important. And I'm not as I know that there's better AI tools for looking up things now than just standard references. Or I don't want to throw any specific reference under the bus. Okay. But there are ones that are better for emergency departments than others, and now there's some better, I think, uh, called open evidence. Some ones that are
Sure.
like pulling together information quickly to answer questions specifically based on data that you can probably trust. So a lot of people I know are worried about AI in the space of giving you incorrect data that you're going to act on, as if that data is going to be more incorrect than our just memory, our human evolved ape. Granted, we go through a lot of training to get where we are, so I'm not discounting that or the ability to know things without AI. I think that's very important. But then I'm really more interested in where AI can interface with you to be on your shoulder as
Yeah.
a little birdie, a little canary in the coal mine to tell you when you're going doing something wrong, or at least integrating through the systems so that relevant data is identified, trends that you may not notice are highlighted. That's going to take a while. I know people are worried maybe about being replaced. I don't know. I don't know that we're going to be there anytime soon. So I'm more interested in how it can.
Yeah. Love it. Well, we have come to the time of the podcast near the end where I like to ask the same question all the time. So here's the question. What is something that's in your life that's so well designed it brings you joy or happiness whenever you interact with it? Is there such a thing?
So I think you know that I'm going to put in a shameless plug for the AirSling, AirSlyng with no space. You can find it on Amazon. I designed it is a um, take on the airline pillow. It kind of straps your head to the headrest and then supports you in a sling that goes over your arms. Anyone who knows sleep science knows that when you fall asleep deeply, you kind of collapse and lose your muscle tone. And this allows you to sleep upright, kind of concept used by astronauts. So I was stationed in the UAE for a few years ago and had to make many, many trips back and forth across the world in coach, and became a bit of an expert in how to sleep upright. And I fashioned a baby sling that I had bought for a friend who had a baby and wound up giving her a different present. So I used this sling on the airplane and found that I actually had a moment where I woke up not knowing where I was, which I don't think I've ever done on an airplane, that I've been in such a deep sleep to be confused as to my location. So the air
Location.
sling is great. I love it. I haven't traveled without it, even when it was in prototype form, but now you can get it on it.
Well, shameless promotion is all we do here at Designing for Health. So I fully support your promotion. The AirSling is on. We will put a link to it on the show notes. So if anyone's interested in seeing more, and then if we happen to encounter you somewhere, you could sign the AirSling.
All the things. Yeah.
I think that would make it even more desirable. I love it. I love it. Thank you so much, Dr. Bonnie Hartstein Shweiki. Really appreciate all of the work that you've done for patients, for the military, and now in the civilian world. Look forward to more of what you're going to bring to us. So thank you. Thanks for tuning in. We hope you enjoyed today's episode. For more on Dr. Hartstein Shweiki, follow her on LinkedIn. Check back for more episodes of Designing for Health wherever you listen to podcasts or on NordicGlobal.com. We'll see you again next time on Designing for Health. If you enjoyed this episode, please leave us a 5-star rating and a review. This helps others find the podcast as well.